Oh, you're muted, Dr. Westphal.
Hello, colleagues. I really appreciate the invitation to participate and share some of my work with you and information around trauma-informed perinatal care and the implications not only for our patients, but for our colleagues as well. I just need to activate the chat here so I can see it. And I'm putting into the chat the handout for the slides. So in case you want to have the slides, they'll be available to you. Start with disclosures. One of the main disclosures that I have is that part of this work is funded by HRSA, and we do have a grant looking at the well-being of the health workforce. As we go into this webinar, I'm going to invite you to think about what I'm going to say here today through two different lenses. The first lens is that of our patients and families going through the perinatal experience, the stress and the challenges that occur with that experience. And the other is through the lens of healthcare professionals, not only for yourself, but also for your colleagues and team members. At the end of this webinar, I hope you will walk away with an enhanced ability to recognize potential stress injuries. So I'm going to expand this idea of trauma and stress a little bit to describe sources of stress injury and to be able to discuss at least one or more strategies that you can use with clients or with each other. So let's start off by taking a look at the perinatal stress challenges. The perinatal experience is a source of family and clinician stress when it all goes well. When it's absolutely perfect, there's significant change, physiological, psychological, social, economic, identity. There's inherent multiple risks throughout the entire period. There's such variability. Each pregnancy is unique, so it doesn't matter if it's the first pregnancy, the second, or the fourth. Each one is unique. And when we have episodes of traumatic birth experiences, obviously this is a major impact on the family and the patient. It's also an accumulative burden and challenge for team members. Most of us have echoes, memories of a traumatic birth experience or a perinatal period that did not go well. And those echoes stay with us as clinicians. When we think about the challenges, we also think about multiple role demands, both most certainly for parents and caregivers. In preparing for the presentation, I went into literature about mommy burnout and the process of burnout associated with the perinatal experience. And it can include feelings of guilt for not doing more while at the same time being exhausted. There's family financial burdens, absolutely disrupted family dynamics, and we know there's an increased risk for intimate partner violence during the perinatal experience. One of my colleagues, Jean L. Husen here at UVA, recently published a study looking specifically at risk factors, perinatal risk factors for women with disabilities. And there's an increased risk for preterm infants, low birth weight, and NICU admissions. There's 50% of women with disabilities will screen positive for perinatal depression. And there's an increased intimate partner violence and a 30% risk of pregnancy from sexual violence. So when we have patients that have physical disabilities, our indicators and our need to check and assess for trauma and stress burden goes up. So why is it important for us to understand trauma within the context of healthcare and particularly perinatal care? Well, in order to provide effective services, we need to understand our patients' life situations that may be contributing to the person's behavior and current challenges. Many current problems or issues faced by people that we serve may be related to trauma experiences. When we have individuals that have traumatic life experiences, that alters their perception of the world around them. And as their stress load goes up, the likelihood that they will respond to a common stressor through the lens of their trauma experience goes up. And so this is where we may see what some families would say is atypical behavior. Have you ever had a patient that was really responding in a very dramatic and fearful way, and a family member would say to you, well, that's just not them. They don't normally act that way. And so those might be echoes and triggers from those trauma experiences. Now, when we think of trauma over the lifespan, it increases the risk of neurological, biological, psychological, and social difficulties. Trauma and trauma experiences changes brain neurobiology. Specifically, the fear circuit and the worry circuit get overactivated. And an overacted worry circuit may present as anxiety and may even be identified as a person with an anxiety disorder. So there's physiological changes with a stress injury. Most certainly there's the social and interpersonal dynamics. We see over the lifespan, when we think about trauma, the adoption of healthy risky behaviors as coping mechanisms. So we see an increase in eating disorders, smoking, substance use, self-harm, sexual promiscuity, exposure to violence. And there is the risk of severe and persistent behavioral, physical, and mental health problems as sequelae to early trauma exposure. As healthcare professionals, when we start thinking about trauma and the trauma narrative within our settings, it's important to recognize that some of what we do in a normal day can often represent a trigger, particularly if an individual had a traumatic experience that included or needed healthcare. So sites, lab coats, medical equipment, restraints, even the pressure of an X-ray bib may be a trigger. Most certainly sounds, dental drills, ambulance sirens, chaos within the environment can be a trigger. And then very powerful smells, rubbing alcohol, antiseptic odors, latex can be triggers. So part of what is important to recognize here is that all of these things we don't control. And any of the things within our environment may be a trauma trigger. And so it's important for us to be able to recognize, is this a trauma trigger that's going on? And then how can we help? How can we address it? I'm not going to go into detail on this particular slide. This is related to adverse childhood experiences, ACEs. And so when we start to think about patients and clients that have early childhood trauma, the echoes from that trauma gets played out across their entire lifespan. So we see significant metabolic and chronic health condition challenges, all kinds of issues related to those ACEs. So part of what this means is that we can have clients and patients that come in through the door and they have a trauma loading that we don't know about, and they may have expertly repressed or compartmentalized until they get in the care environment and it starts to get triggered. So SAMHSA, the Substance Abuse and Mental Health organization, has a really good material around trauma-informed care. And so when we think about trauma and how it's defined by SAMHSA, they talk about the 3 E's of trauma. There's an event, which is actual or extreme threat of physical or psychological harm. Not all events will create a trauma response. So first there's an event. Next, there's an experience. How the individual labels, assign meanings to those events. It becomes really important, and that becomes part of the trigger, whether this is a worry circuit or a fear circuit that gets triggered. And then the effect. How is the individual disrupted physically and psychologically from the experience? It's important to recognize that there is no singular trauma typical response, that it will be variable and it's context dependent. So I'm going to move off of the trauma into stress injury here. So this is just reinforcing this idea of a trauma-informed approach, is that if you're working in a setting that has a high proportion of patients with trauma histories, and your organization is interested in having a trauma-informed approach, then there's some structures and resources for you. And so a trauma-informed approach includes organizations and practices that realize the widespread impact of trauma, that we know and recognize signs and symptoms of trauma and stress injuries within our clients, that the organization and our resources and our care is delivered by integrating this knowledge into our policies and our practices. And it's really important that we actively try to resist or counter the risk of re-traumatization. When we have patients with a trauma experience, what is routine care for us may be an exacerbation or re-traumatization, and particularly when you think about the birth experience, and that can be incredibly triggering. So how do we help to navigate the care that we're going to give and the context for the patient? So now I'm going to shift a bit to this idea of stress injury. There's a lot of knowledge and discussion about trauma, but trauma is not the only issue that's at play here. And when we think about the perinatal experience in the context of broader stressors, I think it's really important that we expand what our concept is of a stress injury. And so stress injuries are similar to physical stress. Psychological stress can cause injury to the mind and body, those activation of the fear and worry circuits in particular. It's important to recognize that these injuries go beyond burnout. I talked briefly about mommy burnout. We know in healthcare that burnout is a dominant issue. Burnout as a concept gets overplayed. Burnout is not the failure of an individual to cope. It is the expected reaction to unbalanced demands to resources. And that's where this comes into the perinatal experience. That's an unbalanced demand, no matter how you define it. Within healthcare and the work that we do, we often have unbalanced demands to resources. When we think about stress injury, it's more than having a bad day. It really is a severe and persistent distress or loss of ability to function. That means there's a change in our patient's behavior, there's a change in our behavior when we have a stress injury. It's important to recognize that stress injury behaviors are often intended to be adaptive for us. If I'm really having trouble engaging with people, I withdraw from people. The use of comfort foods or substances goes up as a way of managing stress. Some people get angry, some people get short, some people get they're withdrawn. So there's a variety of behaviors. So with all of this variety, then how on earth are we supposed to recognize this, particularly in our patients and our colleagues? So stress injury behaviors include impaired or diminished role function. We have many roles. We have work roles, spouse role, parent roles, friend roles. And often what happens when we start to have a stress injury, in order to conserve our energy, we start to pull back from those roles. For many people, we start to pull back from family roles to save more energy for work. One of the things that I've seen in working with colleagues during the perinatal experience is that they'll often pull back from work experiences and to put more energy into family and the perinatal experience. We have individuals that may say they no longer feel like their normal self. Something is really different. They may experience excessive guilt, shame, or blame. And for some, the ability to get irritated is gone. It's either false happy or rage. And so the reactivity around anger may be an issue. So when we think about stress injuries, we also start to think about what are the sources of stress injury. So the first one is wear and tear, and this is a fatigue injury, and this is where burnout sits. That bone weary exhaustion of just doing what you need to do every single day, be it at work, be it at home. Most certainly during the perinatal experience, there's an immense amount of fatigue that goes along with just the physiological changes that are occurring. Next is this idea of life threat, and that's a traumatic injury. So if we experience or your client has experienced a direct life threat, often that happens with intimate partner violence, that changes their perception of the world. The other thing that's important to recognize from a healthcare professional standpoint, our exposure to trauma becomes a collective burden. We have those echoes, so that can stay with us even though it's not directly a threat to us. It's part of our trauma experience. Loss is a grief injury, and there are micro losses during the perinatal experience, losses of time with work, with family, with children, the ability to do some of the things that you intend to do. We absolutely know when there's fetal demise that there's a significant loss event with that. So loss can be very much a part of the perinatal experience. And then there's this idea of inner conflict, which maps to moral distress. And inner conflict can result in what's called a moral injury. I'm going to pull attention to these last three words in this column here. Acts of omission and commission. Omission, I didn't do something that violated my values. Acts of commission, I did something that violated my values. This often results with shame, guilt, and blame being turned inwards. Often we will hear this omission and commission dialogue when there's an infant that's born that has genetic anomalies, and the parent says, is there something that I missed? Is there something that I did that may have contributed to this? The third one is bearing witness, and this is where our partners, our organizations, the people that we work with violate our deeply held values, our core values. And this often evokes a strong sense of anger and outrage. And so that gets externalized. So when we start thinking about risk factors of suicide in postpartum depression or perinatal depression, when there's echoes of coulda, shoulda, oughta, if only, when there's echoes of omission and commission, where we hear guilt and shame, that risk for suicide goes up dramatically because that's being turned inwards. So as a healthcare professional, one of the things that we can do is call attention to what we hear, what we see. And I'll get into a strategy a little bit later, at least one strategy that we can use. So let's take a look at the perinatal experience as it maps and overlays with this idea of four sources of stress injury. So first, in wear and tear, it's changing unpredictable course. Multiple role demands. There's this idea of mommy burnout. There's financial burdens. That's just kind of the base that we would expect with the perinatal experience. There's the possibility of pregnancy complications. There's no such thing as a routine injury or infection. Everything now has a deeper meaning that must be addressed, and particularly are there fetal implications. As a psychiatric nurse and as a nurse practitioner, so much energy goes into making safe medication decisions. with individuals during the perinatal experience, because the goal here is a healthy mom, healthy baby. And how do we navigate that? Experiences of loss, there's family dynamics, job, school opportunities, maybe set aside or delayed, changes in self-identity, and then most certainly the obvious one is when there's fetal demise, there's bereavement. And then inner conflict. This idea of stigma is really interesting because there can be positive and negative stigma around the perinatal experience. How many individuals have been told, you're pregnant, you absolutely glow? And their response is, it's a flare-up of my eczema. That it's not glowing. And so they may be in a family system that is celebrating the pregnancy, but they may be in a really different place in their own thoughts and experiences. There may be guilt related to unbalanced time across social roles, and then most certainly around genetic anomalies. So when a person has a stress injury, it impacts us in a really important way. And the good news here is that we have evidence that says when there's a stress injury, how does that impact us? And so there are 5 essential needs that are impacted. And so first, I'm going to talk about these needs in a positive sense. We all have a sense of need for safety. If we're not safe, then we try to leave. And the complication is when we start thinking about intimate partner violence, where is the safe environment? Calming actions, once we're activated, once the worry and the fear circuit is activated, we need to have the ability to down-regulate that autonomic nervous system, slow deep breath, lower heart rate, lower respiration. Anytime you have said to someone who's very anxious, focus on me, take a breath, you're not alone. You're providing a first aid intervention around calming. We all have the need for social support. The sense that we're not alone in what we're going through. We need competence in daily coping and occupational skills. And think about the amount of time and energy we spend with first-term parents and moms. Just this is normal, this is expected. Trying to help them understand and build those coping skills. And then the last essential need is a sense of confidence or hope that things are going to work out okay. Part of in healthcare, there's a discussion around meaning and mattering. The meaning of the work that we do brings us to the field. Whether we matter, that we make a difference or not, keeps us in the field. And so this idea of meaning and mattering is part of these essential needs. So part of the team that I was on, when we developed a stress first aid model, we took these concepts and we matched them to intervention and actions. And so when we start thinking about individuals with stress injury, what are the essential skills? One, to be able to recognize the potential behaviors of a stress injury. 2 is to act, to engage the person, to assess. And 3, to assist to connect with other levels of support. We may not be the answer or the final resource. We may be a starting point for this person's journey. So how is it that we can mitigate stress injury impact and the impact of trauma? So the Wisdom and Wellbeing program that I'm a co-director here at UVA, I have our website listed here, uses 4 frameworks. I'm going to briefly introduce the frameworks as a way of developing knowledge and skills for addressing trauma and stress injury. The first is this idea of wisdom practices. We don't need to wait to have gray hair to act wisely. It's actually a skill. And part of this is reflective capacities, our ability to see the behavior of others, our cognitive capacities, having the knowledge to make tough decisions and engage, and then our affective capacities. You know, we are really good as healthcare professionals in using these skills with our patients. We're not always so good using these skills with each other. So there's our wisdom practices. We have stress that is along a continuum. It's not either or, and I'm going to expand on the stress continuum coming up. We have 4 sources of stress injury that I've already introduced, and then we have a framework called stress first aid. How do we engage? How do we respond? So around the wisdom capacities, I actually started to talk about this one in terms of the different capacities. So wisdom and wisdom capacities are skills that we can learn and practice, and we can teach others. And the goal is to develop practical wisdom. It's not always to be the wisest person in the room. That tends to be variable, but to at least have some skills that we can act wisely. An example of acting wisely comes from Ted Lasso. For those who are a fan of the series, there's a meme on the internet where he's playing darts. And the quote on here is, "Be curious, not judgmental." And so that's an example of a wisdom capacity. Next is this idea of stress along a continuum. When we think, and the continuum is green, yellow, orange, red. Green is the ready zone where we're well nourished, well rested, having everything that we need to be able to navigate the stressors in our life at the moment. Reacting is the yellow zone. It's mild and transient distress. It's changes in behavior, and it's often the adrenaline rush. For many individuals who work the labor deck, early in my career, I worked pediatrics and was cross-trained throughout maternal child health. And for the most part, working the labor deck was 95% sheer boredom and 5% sheer panic. And so there's that adrenaline rush that comes, and that's a sweet spot. So the green and yellow zone is a wonderful place to be. And as the yellow zone stressors start to resolve, then we're back into the green zone. So this is absolutely normal. What's not normal, but it's very common, is this idea of a stress injury, where there's changes in behavior related to exposure to these 4 sources of stress injury. And these are not transient. They tend to stay a little bit longer. And it's important to recognize that these stress injury behaviors are often meant for the person to help them maintain control in their life and to navigate the challenges. Unfortunately, it also causes more problems and issues. And so the idea with a stress injury is that we want to help people get connected with additional resources so that they can move back towards the yellow and the green zone. The red zone is the ill zone, and this is where individuals need professional, confidential clinical help. And so an example in the perinatal experience is that if you have a patient who's coming into the labor deck who has schizophrenia, and they go into a frank psychotic episode during pregnancy and delivery, and I've had a couple clients like that, there needs to be a psychiatrist and psychiatry team that's working together for managing that person's care. If we think about our colleagues, that we have colleagues that may have underlying anxiety, depression, and they need to be connected with other resources. When we think about postpartum depression and postpartum anxiety, making sure that we do the best we can to help those patients get connected with appropriate mental health services becomes critically important. So we take this idea of the 5 essential needs and what actions are helpful, and that's how we develop the stress first aid model. And so the stress first aid model has core actions. These are things that you can do around stress injury. And these 7 C's are check, coordinate, cover, calm, connect, competence, and confidence. And so we have a stress first aid model. And in the stress first aid model, it's based upon the stress continuum, green, yellow, orange, and red is coming. The green is on the outer edge of the circle, representing that there are many ways to grow the green. And one size doesn't fit all. So what works for one person may not work for another. So helping to understand what works for a person to grow the green is important. The other thing is that we need to recognize that some individuals may have a stress-related illness or echoes of trauma in the past that really need an additional level of support. And so we have the 7 C's, which is the core model, and we start with this idea of continuous aid. And you're doing this already. Continuous aid starts with check to assess, observe, and listen. And is there a possible stress injury? If so, who do we get to help? What other resources do we need to bring in? And we're actually really good at this. We do an assessment around social determinants of health. Do we have a patient that needs to have a connection with social work? Are there other resources? So many times we do this early in the perinatal experience. So I just want to point out that that which we do normally, we wouldn't think of it as a stress first aid action, but in fact, they are. Next is this idea of primary aid. And primary aid stands for primacy, things that we must pay attention to. An example I like to use is that if I'm doing a dressing change on a patient's foot and they stop breathing, I'm no longer worried about the foot. And so what are things that we absolutely must address when they are present or we assess for them? And this is where safety and calming comes in. And when we think about the amount of work that we do to create a safe environment, particularly in labor and delivery, is really important because this idea of safety and calming go hand in hand in that particular environment. Now, if a person is reasonably calm and reasonably safe, but there's still a potential stress injury, those echoes of previous trauma or sources of stress are still present, then we start thinking about secondary aid. And in secondary aid, we have this idea of connect, social support. Who else needs to be there? How many times have we had a patient show up on the labor deck and she says, "Oh, and my mother is with me." And we're going, how do you get along with your mother? Or my stepmother is here, or, is a family member. Is this a family member that's helpful? Who else could be there that has a better connection? This sense of competence, do they have the skills and resources to do what needs to be done? Once again, we've seen time and time again, individuals that have an anticipatory pregnancy and they prepare and they've taken pre-delivery classes and they've practiced. That's a different birth experience from the person who walks in and says, "I didn't even realize I was pregnant, and the ER just told me I'm delivering." Those are two really different competency experiences. And then confidence. What's the hope for the future? And so this is the idea that we can use stress first aid as patient-facing, but also for our colleagues. So one of the things that I want to leave with you in terms of, we have so many assessment to do, and I'm not asking you to do one more. I'm asking you to weave these concepts into that which you already do. And part of the holy grail for trauma work is, how do you ask about trauma without re-traumatizing? How do you ask with, maybe the partner there is still in the room? You can't come out and say, "Geez, are you experiencing intimate partner violence?" That tends to not work well. And so what we can use is these 5 essential needs shaped as an assessment. I understand there's a lot going on in your life right now. Is that ever an understatement in the perinatal experience? I want to check in with you how you are doing today. Do you have any concerns about your safety, your ability to relax, be calm, or sleep? I ask about sleep because the trauma narrative and stress injury thoughts tend to occur often at night. And people may describe, I have trouble sleeping, and you say, is there anything in particular that keeps you up? Now, notice they're sharing what their experience is. I'm not asking them to give me their trauma narrative. Has it impacted your connections with other people, coping or managing your health, your hope in the future, or your quality of life? So weaving these concepts into your assessment then becomes a needs-based discussion, and it can trigger for you, is there a risk for other stress injuries? Is there a potential moral injury? Is there anxiety, depression? What's the risk factors around perinatal depression? This is a tool that you might be able to use as you weave these in. Oh, I lost my, okay. So the next couple slides here are in the handout. And so I'm not going to go into a great deal of detail. Step one, recognize stress injury, that continuous aid, situation awareness. This is what we're doing all the time. And a strategy that we can use for checking with our patients or with our colleagues, particularly if you have a colleague that you think has a stress injury, the Oscar communication is a good strategy for doing that check. And the magic words in Oscar communication is the ask why, help me understand what's going on. And then who else needs the help? If not you, then who else? In primary aid, this idea of cover and calm, we have lots of strategies. Most of us are really good. The primary strategies often start with breathing. Take a deep breath in, slow exhale, focus on me. We do a lot with breath work in the perinatal experience. And so that fits very nicely with calming. And then, cover what are some safety issues, what are safety concerns, and it can be physical safety, psychological safety. We need to address and attend to those. And then strategies and actions around secondary aid, this idea of connection, what social supports can the person engage with or use. One of the things that happened in healthcare during COVID is it fractured our social supports. And we're just starting to rebuild some of those in most of our healthcare environments. So we still have some work to do there with each other. Competence, what are skills and resources about moving forward? I spent 3 decades as a Navy nurse, and the number of really young mothers delivering without family support was pretty high, so much so that the Navy nurses started baby boot camp to help individuals learn how to put on a diaper. What are the fundamental skills of taking care of an infant, particularly for those of you that have worked with adolescents and pregnancy, when children are having children? We cannot assume that they have the competence and skills to navigate this. So that would be a first aid intervention. And then confidence, building hope for the future. So as we start to wrap up, I hope that my presentation and comments about trauma-informed care, the trauma narrative within the perinatal experience, and inviting you to think about using a wisdom, well-being, and stress first aid approach for not only our patients and family members, but for each other has been useful. So with that, we have a little bit of time for some questions, so I'll open it up for questions.
Thank you, Dr. Westphal. If you have any questions, please feel free to put that in the Q&A. You can also put it in the chat, or you can come off mute and ask if you would like to verbalize it.
Hello, Dr. Westphal, can you hear me?
Yes, I can. Go ahead,
Yeah,
please.
hi, Chris Chisholm from Maternal Fetal Medicine at UVA. Thank you for an outstanding presentation. I think many of us have probably heard several talks on trauma-informed care, and I think this was really very accessible. And I appreciate slide 23, because I've been trying to find the way to uncover when a patient has experienced trauma, and there doesn't seem to be, I mean, we have our tools to screen for substance use disorder and intimate partner violence and do that in the right way. So I think this is going to be enormously helpful, and look forward to weaving it into my practice and encouraging other people to do the same, because it isn't always staring you in the face. It isn't always the patient who had an abruption and an emergency cesarean and a baby who experienced a birth-related injury as a consequence of those things. It may be an adverse childhood experience or some other event that isn't so obvious to us in the course of a busy prenatal visit.
Yeah, thank you, Chris. And most certainly as a trauma therapist, I struggled for years. How do I have a discussion around trauma with people that have really serious trauma without re-traumatizing them? And that's really a challenge. The other point that you bring up is that if you recognize that the patient you're working with seems to be having an overwhelming to extreme response, and there's a safe moment in time, then you can use a statement that says, I understand there's a lot going on in your life right now, and I'm going to ask you about 5 things to help me understand, to be able to provide better care for you and your family. And then you can go through that list. Okay, other questions?
Thank you again for a wonderful talk.
You're welcome.
Dr. Westphal, this is Tracy Walters. I work at the Department of Behavioral Health and Developmental Services in Richmond, Virginia. Thank you so much for the presentation. And I am not coming from a clinical field, but I am the state coordinator for infant and early childhood mental health here. And so I'm just looking at this information and thinking about so many ways this can be used with families, with our practitioners that are working with families in a mental health capacity. And so I just wanted to thank you for sharing all of your information. And I know that I will continue to revisit this because I think the implications for this framework could really be used in so many ways, in leadership and leading teams and the infant and early childhood mental health space, certainly in social work. There's so many ways that this information would be very useful and helpful. And so I just thank you for the hard work that's gone into this.
Thank you, Tracy. Just to let you know, when we rolled this out in the Department of the Navy, we had a family-facing model. UCLA social work department had a contract with us, and they developed Families Overcoming Under Stress Focus, where they took these principles, and one of the first things we did is we created a refrigerator magnet out of the stress continuum, and we taught families how to use the stress continuum to talk about the challenges that they were having in the moment, rather than shouting, screaming, and some of their standard behaviors. So thank you for that.
Yeah, thank you for that, because this is also where we can help stop or mitigate generational trauma, right? When we start to deliver these skill sets for families who are raising young children, and if they have this framework to lean into, we can really mitigate that generational trauma that could continue to go on and on. So thank you. This is really amazing work.
Okay, and I think we have time for one last question or comment. Okay, so we have the handout. The slides are available for you to download. And as we start to wrap up, thank you so much for the work that you do, for caring for the next generation and families, and so much so for the women who are at greater risk for violence and trauma related to the perinatal experience. You're at such a pivotal point. So thank you for what you do. I hope this information will help you in your practice.
Thank you, everyone, for joining us today. Remember, you can see the recording of this presentation on our YouTube channel. Feel free to rewatch it or to share it with others from there. Give us a few days and it'll be posted there.